Okay, good afternoon. We are going to go ahead and get started. Welcome to the House Standing Committee on Health Services. This is our first meeting of the session, so welcome to everyone. We will go ahead and call the meeting to order, and DJ, please call the roll.
Representative Bentley. Here. Representative Bratcher. Here. Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camule.
Here.
Representative Duval.
Here.
Representative Frazier Gordon. Representative Justice. Representative Neighbors.
Here.
Representative Rayburn.
Here.
Representative Raymer. Here. Representative Riley. Here. Representative Rourks. Representative Sharp.
Present.
Representative Wilner.
Here.
Representative Whitten. Vice Chair Dotson. Chair Mosier.
I am here. Okay, we have a quorum established to do business. The first order of business will be a bill for consideration today. And I see that the bill sponsor, Representative Rebecca Raymer, is at the table. And we will hear about House Bill 174. So if you can just identify yourself for the record and proceed.
Representative Rebecca Raymer, District 15. So I'm presenting House Bill 174 today. It is a bill pertaining to medical records of minors. This is just a clarification so that a parent can maintain access to a minor's medical records. We've had some instances where once a child turns 12 or 13, the parent has lost access to the medical records until the minor comes in and signs a consent to allow the parent access. Now, we have certain things carved out in law where minors can seek treatment for certain things. This does not affect that. The last line of the bill says that unless protected under HIPAA or any other federal or state law. So that does not affect those instances. I do have a testimony from a mother in my district where this affected her. I'm going to read. Our son is 13 years old and has had multiple health issues since birth. He has immune system deficiencies, a failure to thrive diagnosis, as well as fine motor delays stemming from a genetic mutation. Having access to test results, growth chart reports, and all other medical records is a must in our situation. After he turned 13, we received communication from several of his healthcare providers stating we would no longer be able to access his records that contained information from his 13th birthday forward. We were told he would have to give the provider permission for us to access his records, and to do so he would need to physically, not electronically, sign documents stating his consent for us to oversee his care and to access his medical records. When I spoke with one such provider and informed him of his inability to sign his name due to fine motor delays, I was informed we would have to meet with their attorney who would assist us in the process. We are struggling to understand the methodology behind this, as no healthcare provider we've dealt with, and we've had a lot of them over the years, bats an eye at the age a person that is paying for the bills for the services, but they refuse to give us access to see the results. Common sense should tell you that most 13-year-olds don't have the maturity to handle these items. So this is just trying to make sure that in those instances where it's not already carved out in state law, that a parent maintains access to the records. I'm happy to answer any questions.
Okay. Thank you. Representative Wilner.
Thank you, Madam Chair. And thank you for the bill. And I hear the intent of this. I'm always concerned about unintended consequences of the bill, as I think we all are as policymakers. And I guess I'm wondering about in cases of someone under 18 who's seeking reproductive health care and how this might affect that.
So, like I said, the last sentence of this bill has it carved out that it's any other state or federal law, it's protected. So we already have those instances in statute, so it's not going to affect those circumstances of those records.
Thank you for clarifying.
You're welcome.
No, thank you, Madam Chair. I appreciate it, and you nailed it. Good job.
I just have one question, one concern. There are a lot of kids across Kentucky who live in violent households, and my concern, I've growing up, my family actually took in kids who were suffering from different forms of abuse in their home. One of my concerns is disclosing health care, either healthcare decisions or getting healthcare needs would prohibit these kids or make them fearful of seeking the care that they actually need. What do we do in those instances?
Well, I don't think this has anything to do with consent to treatment. I mean, every facility and provider has, guidelines on treating a minor. You have to get the permission of the parent or the guardian. They usually have you sign a consent to treat. So this isn't stopping anybody from seeking treatment. And, I don't know any providers other than those circumstances that we have carved out already would be granting care to a minor unless it was an emergency situation. But we do have, mental health is carved out in statute. All the reproductive issues, those are carved out already.
May I ask another question?
Yes.
Oh, thank you. So, again, I don't think I didn't phrase my question well, I think. I don't think it is a matter of just the disclosing the healthcare decisions. For kids who live in households where they have fear, my concern is that they will not seek the care that they need out of fear of what would happen in the home if it's something that the parents don't agree with. So that is my concern. I hope that clarifies what I was asking. I don't think it necessarily protects all kids. I think it accidentally may put kids in harm's way, and that's my biggest concern.
I think I see what you're saying. I disagree, because I think that those instances are already protected. I think that we just have facilities that are restricting these records too early in instances that aren't protected. I don't think that we have instances where if a child is at danger, again, the parent or the guardian has to take them in to be treated. They're not going to be, and if there is, a provider is bound by law, if they suspect abuse or neglect, they report that.
Okay, thank you. All right, I don't see any further questions. And, Representative Bratcher, sorry, I didn't mean to skip you.
Thank you, Madam Chair. Thank you very much for bringing this bill forward. I've had a couple of people come to me, parents that are concerned because they cannot get medical records for their children. And they have the sole responsibility, both legally and morally, to take care of their children. And the medical community and some medical communities are restricting access to these records. And how can a parent decide or a guardian decide the best interest of the child if they can't see the medical records? So thank you for bringing this forward.
Thank you.
Okay, thank you. I would just like to note in support of your argument for this that the state law, KRS 214-185, governs that a 16-year-old's access to outpatient mental health counseling is allowable, and this bill will not supersede that or treatment for an STD or other, as you said, reproductive issue, notwithstanding abortion. But so I think that we've been really careful to maintain that provision. So, all right. Seeing no further questions, we have a motion on the bill and a second. Thank you. All right, DJ, please take the roll.
Representative Bentley?
Yes.
Representative Bratcher?
Yes.
Representative Bray? Representative Burke?
Pass.
Representative Callaway?
Yes.
Representative Camuel?
No.
Representative Dotson? Representative
Yes.
Representative Frazier Gordon? Yes. Representative Justice? Representative Neighbors,
Yes.
Representative Rayburn,
Yes.
Representative Raymer,
Yes.
Representative Riley, Representative Rourks,
Pass, and I'd like to be counted as present today.
Representative Sharp,
Aye.
Representative Wilner,
Brief explanation.
Yes, ma'am.
I really like the intent of this. I want to just do a little more reading, so I'm just going to pass for today. Thank you.
Representative Witten, Chair Mosier.
Yes. Okay. House Bill 174 passes with favorable expression, and the same should pass on the House floor. 11 yeses, 1 no, and 3 passes. The same should pass on the House floor. We do have some members who will need to record votes. We have state government going on at the same time. So thank you so much.
Thank you.
Okay. Next, I would like to hear an overview and update on our mobile crisis units here in Kentucky. So welcome, Secretary Friedlander. And if you could just identify, both of you identify yourselves for the record and proceed.
Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
Leslie Hoffman, Deputy
I don't think
Commissioner
it's
for the
on.
Department of Medicaid.
There it is.
Sorry.
Thank you for the opportunity to present today. This is, I think, a very exciting program. This actual contract for this went up in front of Contracts Review Subcommittee last week. There is funding that was provided for this program both in the governor's budget and, as I read it, in the House's budget as well. So I appreciate the opportunity to talk about this program. This is something that I know we rarely do in state government, but this is something you're going to have to think about over the long term. This will not be a quick implementation. We're talking about a 3-year implementation. We've probably already been working on this 3 years. So this is a program that we hope has impact on local communities. And so it's really, you have to think about this as a set of programs. It's hard to kind of isolate the separate pieces, but I will do my best now to give you a good explanation. So oftentimes in our local communities, we find that we have folks who are in crisis, behavioral health crisis, substance use crisis, and so this is a way to address some of those concerns on the local level. First, with a set of services. Those of you from the Louisville area remember that there were some programs that were put in place. The Living Room, for example, that 23-hour, 7-day-a-week program. Some of the mobile crisis pieces that we were doing around folks actually going in and trying to get folks to services. And they kind of fell apart because Medicaid was unable to participate. So what this program does is it sets up the framework for folks to be able to participate. We are bringing in a contract entity. It's called an ASO, Accountable Services Organization. You know, we love our initials. But it is, those of you who've been in the legislature for a bit know that you passed what was a Senate Bill 50, which was the single PBM, and turned into a single prescription piece where that group, all the pharmacy runs through that group, and they talk to the MCOs about, hey, you're going to pay this, we've approved it, you pay it. Very similar with this with mobile crisis, right? We're going to have a group that helps us really evaluate and help set up programs locally. So that's the ASO. And they'll work with local providers. We're requiring that they work with our local comprehensive care centers. How we say that is they have to work with the group that's operating the 988 line. So they're required to do that. Those of you familiar with law enforcement know. 10 to 20% of the calls that come into our local law enforcement agencies are often behavioral health issues or substance use issues. Having worked with my local law enforcement group when I was in the city of Louisville, local law enforcement, even with the CIT training that we have across the state, which is very good training, those are the calls that nobody likes to make. Those are the runs that nobody likes to go on, because that dealing with somebody in a behavioral health crisis or substance use crisis takes a specific level of expertise around de-escalation, around getting folks to services, making sure that there's a place where they can de-escalate. That's what this first piece of mobile crisis does, and provides some services so that the first instinct or the only option that somebody might have is to take somebody either to an ER or a jail. This provides an array of options in local communities. Again, remember, this is a 3-year implementation. This provides the framework for those local communities to come up with what that service array and how to arrange that service array. There's a second piece, an EMS, an ambulance. Formerly, the only way that an ambulance could get paid is if they transported somebody to an emergency room. So again, think of this as pieces together. We are now allowing ambulances to transport somebody to a service provider, to treat in the field, so that they don't so that their payment doesn't depend upon them delivering somebody to an emergency room. It allows some of these 23/7 places where ambulances can go and take folks. It will assist folks in having a behavioral health specialist respond in all likelihood with local law enforcement. There was an announcement last week. We have set up some grants for local communities, not the state dictating to the local community, but the local community to come up with a 3-year plan for how they would respond. We had local governments respond, we had local EMS respond, we had local fire respond, and we had local law enforcement respond. So we have this array of service providers who've responded to what is a grant, a 3-year grant, $850,000, to develop their plan on how they're going to integrate their services with what we're doing in mobile crisis. Again, it's a 3-year program. First, we're not requiring any match at the local level. Then there's a little skin in the game for the local folks. About 10%, it can be a local match. We will be as creative as we can possibly be on what that local match will entail. And then the last year, it'll be a 50% match. But again, to give the communities the opportunity to design their local response. So as you see that this slide kind of lays it out. There are a lot of words. It's a little bit of an eye test, but hopefully you have some of this in your package. We'll send it to you. But we think once we get these communities working, other communities will be interested in participating as well. We probably had more people interested than, frankly, more communities interested than we had funding for. But we'll continue to work on that, because I believe it's very important that we do this in partnership with local communities. Leslie, is there anything you'd like to add?
No, a lot of the, I guess a little bit, I'll just mention about the crisis co-response. It has been so exciting and humbling to see that folks want to make a difference in their local area, and a lot of folks have good programs that might be limited in funding or can expand to that nights and weekends, or really want to involve a licensed clinical social worker with that team but don't have the funds. So we've enabled them to do that, and the messages that we've heard, like I get emotional a little bit, because it's very humbling that these folks want to help their own communities and their neighbors next door. So, we want to make sure that we can meet that person at their place of crisis, whether it be their home or McDonald's or the park, and get an appropriate level of care to them, not something that's more restrictive, and divert them to a better option for a quality of life.
This also, obviously there's some piece that relates to homelessness and the folks who are on our streets, in our parks. And I served with some homeless outreach groups in the city of Louisville. But this is not an urban issue. If you ask anybody across the state, we are seeing more and more folks. I know you've heard testimony around some of the issues with substance use, increased substance use disorder, as well as increased behavioral health issues. This is a way for every community, every county in the Commonwealth to figure out the best way that they can respond to that. So this just kind of gives you an example of how that might flow. So a call somebody's in crisis, a call comes in all likelihood to either 988, which you know there's a bunch of calls, but the calls that you actually need to respond to and send somebody out is probably a fairly low percentage, or 911. So making sure we have that coordination on the local level. Somebody calls in and it really reads more like a behavioral health issue or substance use issue, then that could be funneled to this crisis team that's going to go out and provide assistance. You see, with dispatch transportation, that's a part of this program. There are all sorts of potential assessments, and then really the referral to hopefully some ongoing services. But this provides that very, very front end of really kind of de-escalating individuals and really working on having somebody in a relatively stable place, right? At least more stable than when the call came in, to be able to get to services. So part of that is making sure that there's it's overused, but making sure that there's that warm handoff or there's that really specific handoff between service providers on the local level. Again, that ASO will partner with us and partner with the local behavioral health providers to make that handoff possible. So, as I said, if you think of it as just one piece, this is a systemic I don't know how to say this, a systemic intervention. Within the budget, there's a little bit about an incarceration piece. There's a little bit about individuals with SMI. I've talked to you about the ambulance piece. So you have to think of it as all together to get kind of a comprehensive view. I want the next slide. When we went out, with the Administrative Office of the Courts. Some of you may have attended some of the town halls that they had, and it was the Administrative Office of the Courts and Behavioral Health. Every single community that we went in talked about how this part of the system isn't working locally. And to a person, I think you were Chairman Moser at the one in Northern Kentucky. We heard all over the state. And as this group has worked together with the and I need to thank the Chief Justice really for putting a lot of this together. We're so thankful to be able to partner with them. But they're working a lot across systems. And they have what is called, again, those of you may be familiar with the law enforcement concepts, this is called a sequential intercept model. And what it means is there's places along when a person interacts with the justice system where perhaps interventions can be made to divert people from jail or divert people from reoffending or, in this case, divert people from getting arrested and sent to jail in the first place. So Senate Bill 90 really deals with kind of that somewhere between intercept 2 and 3, going back along the intercept model. The mobile crisis piece, you're really looking at that intercept 0 to 1. So between Senate Bill 90 and this initiative, we will have places where we can intervene along the model to provide those folks who need behavioral health or substance use help with that assistance to keep them in services, hopefully. I know we've talked about this, but to get back to a living wage job, we hope, and to not overly burden our local and county jail systems. I can't give you an estimate on savings. We don't know. This is a program that we really will be, I think, at the edge of trying to address these issues, maybe in the country. So we're going to learn as we go through. And as with any new program, I promise you we will make some mistakes, but I also promise you we will learn from those. But I'm very excited about this. When I was doing homeless outreach, it just became apparent to me that this part of the system just doesn't exist in many areas. And this is the part of the system where you talk about prevention, and you talk about real savings, and you talk about real difference in communities. I think this has an opportunity to make that kind of difference. So I'm very excited about this. I think you can tell. Again, this is not a snap of a finger. This will not, 3 months from now, I don't, happy to come back and report on it. But, I'm hoping that we start to have some data by the end of the calendar year, and hopefully be able to tell you how we're building as this goes along. But I want to be clear. This is not going to be fast. But I think it's going to be very impactful.
All right. Well, I just want to thank you for all of your work on this. And I know that most people know that I've worked in this space before coming here as drug policy director. And so it's so critical identifying those barriers that address or prevent a continuum of care for individuals who are suffering with either a mental health issue or a substance use disorder or whatever the crisis may be. And I'm thrilled that this piece is being implemented. I think it's so critical. When I was drug policy director in Northern Kentucky, we started a quick response team, and it's similar to this. It addresses someone who has suffered an overdose and follows up with they or their family. And I'm wondering if this program will interface with existing quick response teams. I think I know we have one in Northern Kentucky, in Kenton County specifically. I think Fayette County may have their own version, and maybe Jefferson as well. So for those existing programs, how do you plan to, or have you thought about how to really interface with those folks and be able to scale up what they can do?
So the answer is yes, right, clearly. Fayette, for example, was one of the counties, so they have an existing program, but they're one of the counties that received some of this planning grant money, so we could figure out and work with Fayette to how to integrate their model and how our model integrates with them. So that's an example that we'll be able to use then for Kenton and Jefferson as we figure out how to make it more seamless and how to work together. That's the plan. The 6 areas, Fayette,
Warren, Perry, Cynthiana, Maysville, Christian, and Bull.
Okay.
So,
can you pull your microphone a little bit closer? Sorry.
Lexington, Warren, Perry, Cynthiana, Maysville, Christian County, and Bull were the awardees.
Thank you.
So you see we're trying to get different locations, different populations in the state. I like that distribution, and so I'm hoping we're going to get examples for everybody across the state on what the best way is to develop these programs locally.
Okay, thank you. Yeah, I think this is wonderful. We talk a lot about the programs that we have for justice-involved individuals, and I love the sequential intercept model. I was part of working with the Supreme Court and getting that here, so I love it. But this really addresses the individuals who may not be justice involved yet, and we really want to prevent that and just get them into the services that they need. So anything that we can do to help, I think this is great, or maybe I should just speak for myself. But all right, we have a few questions. So Representative Bentley.
Thank you, Chair Lady. Secretary, being from a rural county, how does this affect them, or how do they apply for it?
So one example of a county that applied for a planning grant is Wolf, and so we put it out for kind of like we do in CHFS for folks to bid on. We reviewed that. Everybody's going to be eligible for this. The second piece of this co-responder model, we bring that up because we know we're going to need to understand better how that works at a local level. So these grants are to help not only teach the communities, but to teach us what the best way is going to be, or what the best ways will be to implement this program. I've had folks say, well, what exactly is this going to look like? And my answer is, we don't know yet. And that's because we're working on these planning grants, and we're going to learn with our local communities, our ASO, as they figure out the rest of the state. The whole state's going to be eligible. That's why it is on a statewide basis. But then how you integrate with a local community, I think we need to learn some about that. Is that helpful?
Please. My follow-up is, this could possibly be a forerunner of essential EMS.
Yeah.
Isn't that a good idea?
Mm-hmm.
Could you tell me how the money flows? Does the, what do you call it, ARS?
Yeah, ASO, yeah.
ASO. Do they pay the providers then?
So in some ways we pay the ASO. They do part of what they do is the grants. The other part of what they do is help local communities set some of these up even outside of that, and make sure that they have how the flow of services goes. But then when a service is provided, essentially the ASO will approve the service, and then the MCO is required to pay it, like we're doing with the PBM. That's why I brought that one up.
Okay. Thank you, Secretary. Thank you, Chair Lady.
Thank you. Representative Wilner.
Thank you, Madam Chair. Thank you for this presentation and for the work, and thank you for making sure that all the structure is put in place first. I'm one of the many people in Louisville who are heartbroken about what happened with the Living Room Project, and know how desperately that is needed. So thank you for that. I'm curious how this might or might not intersect with diversion programs like in Lexington, the mental health court, or in Louisville, the assisted outpatient treatment court. And do you see a natural intersection there?
There's a natural intersection with diversion. Absolutely. And hopefully once we get this up and running, it will be a natural intersection with, who goes out on these calls. A law enforcement officer backed up by behavioral health, law enforcement and behavioral health together, behavioral health backed up by law enforcement. That's what we're not dictating, so that there will be interface there. The courts, that's really down the line on the intercept model a little bit. So I don't think there's as much interface there. Yeah. Where that interface will be is where we have how the courts then can relate to the services we're able to provide through the system. An important distinction, and thank you for asking that question, because now I'll be able to explain it. Once you're in the courts, right, you really would be dependent upon what insurance you have in terms of what services you can access, and that's just true, right? This model, there's some general fund dollars in here, so that if somebody comes in, they're not Medicaid eligible, maybe their insurance company doesn't pay for this kind of thing, we have some funding so that we can be agnostic as to payer source, so that we'll be able to not leave local communities on the hook for the money if somebody didn't have the right insurance. So this model is really different, because it will be, you come into this model, we will make sure that local communities get paid and don't get left on the hook like we do way too often. So, but that won't be the, once you get into the court system, that'll be different.
Okay. Thank you. May I ask one more question? Thank you. That was very helpful. So we've talked mainly about behavioral health crises and so forth. I've had a constituent reach out to me asking specifically about dementia situations where we may have a person who's wandering, and how someone like that might fit into this, and as part of that question, does there need to be specific language somewhere in the in the crafting of all of this that this would in fact serve individuals struggling with dementia?
I'm not sure we contemplated that. Yeah, Leslie, can you?
One of the things that we wanted
You'll
to
need to pull the microphone close.
one of the things that we wanted to make sure is that everybody in Kentucky would be served. We know that, and I've given this example before, a person that's 21 years old with anxiety and depression is not the same response as I want with an elderly person who has dementia. So we want to teach and train everybody on all those specific areas. We've got training for multiple different areas. Actually, too, on the Alzheimer's Association, on a national level, they've offered their training to us for free. So we've been working through that. So yes, a person with dementia that had a call, we definitely could go out on a crisis call for them. I did want to mention too, if I may, we've already started lots of education with the Judicial Commission, as well as I've presented at the mental health courts, the circuit courts, and we're doing the Judges College. So to tell them that they have other options out in the community, but this is our mission at CHFS of how we would like for this to play out, even going into the reentry waiver, which you all are familiar with.
Okay. Again, very, very helpful. But to the part, does there need to be specific language included somewhere in the policy documents to make sure that that's a piece of this, or is that implied somehow?
Yeah, I think it is covered, but I just want to go back to there's going to be a lot of training and a lot of local variation.
Right.
So I do believe that, again, going back to kind of that timeline for implementation, that's why I want to say it's not a snap of the finger. It's going to take time to be able to get all those pieces in. Some local communities are probably going to start out stronger with juveniles, right? Some will start out probably stronger. The recovery-ready communities may be stronger in terms of their initial response around substance use. So local communities are going to have their strengths, and then we'll have to augment those as time goes on, if that's helpful.
Thank you.
Thank you. While we're on this topic, I'm just thinking about a program that we put into place a few years ago with the recovery-ready communities. And I think that's a really valuable tool in this instance for assessing the resources available in communities, because it is going to be different in every community. And so, I think that that's maybe a strong place to start, working with fiscal courts to see what has come of their assessment, and to understand what the resources are. So, just throwing that out there. And then also I had a question about ASOs, what they are, administrative service organizations, and who's the state contracting with, or is this an RFP kind of process? Do they provide oversight and data collection? I think that's all a really important piece of this, referencing the recovery-ready communities, kind of tying it all together.
I'll take a stab at it, and then Leslie will correct me. It was an RFP that we put out. Carillon's the group that won that RFP. The expectation is that there will be data and evaluation pieces of it to see what it is that we're providing. We also required, how to put this, that they had to be conflict-free. Right? They couldn't already be, we weren't going to award an RFP to somebody that was kind of already doing business in this area in Kentucky, because we didn't want to, get it. There are too many times when we work with providers who have interests in addition to ours. There, shall I say that? So we wanted to make sure that wasn't a part of this. So that was all a part of the RFP. Leslie, do you want to?
I was just going to say that we probably, we did a really deep dive for the first year. We had a planning grant that we applied for and got it. We did boots on the ground, talking to lots and lots of folks about the needs to identify the needs in Kentucky. We completed a 258-page needs assessment based on what we heard from others, not what we thought was what Kentucky needed, is what we thought, what others thought that we needed here to be successful, as well as members, EMS, police officers, and things like that. We wanted to have an oversight of this multifaceted model. I will tell you that we are I've not seen anybody that even comes close to what we're doing in Kentucky, especially with the whole array of the intercept. So that's very exciting. But we needed somebody that could do that oversight, that didn't have a vested interest as a biller for that service. We wanted to make sure that they could meet the multiple requirements that the federal government is going to have with us, as well as the grant. We've got lots of things that are wrapped around that grant that we have to ensure that are correct, and oversight, training, provider network capacity, and that to help us with getting the access of less than 60 minutes. I would really like that access to be much, much less. So if a co-responder is available and they're 20 minutes away, they're probably going to get called. So we want, there's enough to go around, unfortunately, in the U.S. as well as the state of Kentucky for crisis situations, and we want it to be very quick on our feet.
Thank you. You answered my next question about a community needs assessment. So I think this is a brilliant plan. I'm excited that Kentucky is at the forefront, and streamlining all of this it's a lot of moving parts.
Yes.
So, okay, we have a couple more questions. Representative Justice. Do you have okay, no question. And Representative Callaway. Do you have a question?
Thank you, Chairman. Thank you for presenting this, and somebody who does represent portions of Louisville. I do appreciate the recognition and some of the focus and attention that's been drawn to that. What I do see in some of my more rural area is community services that are very, very effective, the neighborhood services. My concern is that they're not going to see any of the financial reimbursements or benefits of contributing to something like this. So that's just a concern that I have that I'd like to keep in mind. I do like the idea of the community being this thoroughly involved. I know that's a challenge. So I appreciate y'all taking that on. And I still am learning some of the acronyms. So just bear with me, the MCO that will be required to pay. And that question was answered, the RFP that we were discussing. So I apologize as somebody new in on the health committee, fairly new on the health committee. But I do, again, just want to thank you and voice those concerns that we do make sure that we're recognizing, and that our goal isn't to put more dependence on Medicaid, that we are actually helping and getting them back in the workforce, not creating new customers. And with those wraparound services, there are plenty of wraparound services, at least within my district, that are willing to jump in and do that. And so I just want everybody at the table and having these conversations. So thank you again. Thank you, Chairman.
Thank you, Representative Callaway. And I appreciate your point very much. I know that it's confusing when we throw these acronyms around. So in this instance, sounds like the ASO, the Administrative Services Organization, will be coordinating the care with others and working in the community to tap into the resources that are available in your community. So I hope that helps kind of flesh this out a little bit. And then the MCOs are the payers. So, yeah, we need a flow chart. I understand. Okay. All right. I don't see any further comments or questions. I really appreciate the conversation and the update. I think this is an exciting program, and it's just one more program that we can kind of insert into the timeline or the continuum of care that we are hoping to provide for our patients. So thanks.
Thank you.
All righty. Okay, I think we need to allow some members to record votes. So if you had to step out for state government or otherwise, Representative Justice, would you like to record a vote? Okay, turn your microphone on. Thanks.
I'll be a yes on the medical records, House Bill 174.
Thank you. Okay, all right, I think that's all for now. Okay, next, we have a very exciting presentation on the epidemic of obesity in Kentucky. And I am thrilled to have with us Ms. Jenny Goins, who is the president and CEO of Kentuckiana Health Collaborative, and then Dr. Christopher Bowling, who is a retired pediatrician, my kids' pediatrician, and now you are a volunteer professor of pediatrics at the UC College of Medicine. So thank you so much for being with us today, and just introduce yourselves for the record, and feel free to proceed.
Thank you, Chair Moser and committee. My name is Jenny Goins, as Chair Moser said, President and CEO of the Kentuckiana Health Collaborative.
And I'm Chris Bowling, retired pediatrician from Northern Kentucky for about 30 years, and still active in pediatric obesity for the past 20.
So if I asked for a raise of hands of how many of you know who the Kentuckiana Health Collaborative is or what we do, Chair Moser may be the only one who raises her hand. We have been around for 20 years. We are based in Louisville, Kentucky. We are an employer-led, multi-healthcare stakeholder organization, so we bring in the employers who purchase healthcare, but also providers, the payers who pay for healthcare, other nonprofit organizations interested in healthcare in our communities, and our goal is to build healthier communities through high-quality, affordable, and equitable healthcare. Our strategic focus areas are maternal health, mental health, and obesity. And so I'm here today to talk to you, and I really appreciate the opportunity for this conversation, to talk to you about obesity. Really, I have the employer perspective. I am not a medical person, but I will tell you, over the years running health plans, I was former commissioner of the Kentucky Employees Health Plan. You have to learn a lot about different disease states and understand the data so that you can make decisions about your health plan. And so that is my knowledge of obesity. I'm also a member of the National Alliance of Healthcare Purchaser Coalition's Obesity Work Group, where we're bringing in providers and purchasers to talk about the chronic disease of obesity. And you may be surprised at the word epidemic in the title of my slide, but I do think, and if you read the Wall Street Journal or any other health news organizations, you'll see that it is considered a health crisis in our country and in Kentucky. In Kentucky, I have seen as high as 50%, 40%. I prepared this slide deck yesterday afternoon. So I went out to the the county health rankings. You can get a lot of valuable data there. Some of you may use that website. So you can see that in Kentucky, even if you can't read the numbers, I know you have the PowerPoint in your handouts, but look how dark our rural communities are. So when we're looking at it, I'm speaking about adult obesity. Dr. Bowling will talk about it from the pediatric perspective, and it's a shame we have to talk about it from that pediatric perspective, but we do. 37% of adults in Kentucky have a BMI grade of 30 or greater, and ranged from 33 to 46% when you look at that whole range of Kentucky. And again, I want to stress the rural communities, the eastern communities, also in the far west, in the south. All of our communities, for the most part across Kentucky, are really struggling with obesity. This is why it's one of the focus areas for the Kentuckiana Health Collaborative, and that's why I use the term epidemic when I look at just who we are in Kentucky from a chronic disease perspective. I've been able to work from different roles in the diabetes space. This is as or more scary as a chronic condition as diabetes. I will share with you, some of you who know me may know that I spent 25 years in the Air Force. When I was in the Air Force, if you were overweight, it's because you were lazy, you wouldn't step away from the table, and you didn't exercise enough. It was just a fact of life. Of course, I've been retired for 20 years now. That's hard to imagine, but I have been. In the last 10, 15 years, we have come to better understand and know that what I thought when I was a young airman in the Air Force was not true. Obesity is a chronic disease, and I'm speaking to some of you who already understand this, but whenever I speak about the disease of obesity, and I didn't start my timer, when I speak about the disease of obesity, I have to think about what has been happening and what we know from that chronic disease perspective. And what is happening is what we see a lot with people with the chronic disease of obesity is that they gain weight and they lose weight, but it's not their fault. And that's that stigma of obesity. We think it's people's fault. But what happens is that gut hormone, again, I'm not a doctor, I'm not a scientist. Many of you are doctors and you are scientists. But what I've learned is that that gut hormone is working against you. I really like this concept of what is happening to our bodies when we have the chronic disease of obesity is our body and our brain and our gut start working against us, so that no matter how many times we lose the weight, our body wants to put that weight back on. I had a young lady come talk to the employers who belong to the Kentuckiana Health Collaborative. I almost said my old job, but the Kentuckiana Health Collaborative. And I had one of the folks who has a CFO background call me up and say, I've always thought of the financial aspect of whatever I'm working on in healthcare. I've never thought about the patient. When we think about healthcare, we need to be thinking about being fiscally responsible, of course, but we also need to be thinking about the patient. And this patient had struggled with obesity since she was a child. She had done everything she could. She had trainers. She spent her own money. She had bariatric surgery. No matter what, until she started taking anti-obesity medications, having that kind of, I'll talk about the three pieces of this chronic disease, she always gained the weight back. And that's what this slide is telling us. There are 60 plus comorbidities associated with the chronic disease of obesity. I have opportunities to speak to employers and others about the chronic disease of obesity. And you're going to hear me say that word over and over again because I think we have to say chronic disease of obesity to make sure people understand it is a disease state. But from an employer perspective, and even in your shoes from the Health Services Committee, we need to be thinking about what the cost of this disease is. And when we look at the cost of this disease, if I ask any employer what their top 10 spend is, they're going to have GERD, believe it or not. They're going to have GERD in their top spend. They're going to have diabetes. They're going to have cardiovascular disease. They're going to have hypertension. They're going to have osteoarthritis, knee surgeries, etc. All of these things are components of the disease of obesity. So I'm not saying that dealing with obesity is like a magic area where if we deal with that, we're going to fix everything else, but we can't fix everything else if we don't think about what the disease of obesity is doing to those comorbidities. I can tell you when I I was commissioner of the Kentucky Employees Health Plan, and the Kentucky Employees Health Plan is a member of the Kentuckiana Health Collaborative, and so all of our employers, we talk about this. When I was with the Kentucky Employees Health Plan, we did a study on diabetes. We helped people make sure they took their diabetes medications, and their other medications went down. So we did a year-over-year study. We're not quite there yet. We don't have those studies, but I believe if this can happen in diabetes, if you manage your diabetes, your blood pressure will go down. Your other disease states will go down. So why would we not think that something similar would happen with obesity? On the work group that I'm on with the National Alliance of Healthcare Purchaser Coalitions, Dr. Angela Fitch, I knew I was going to say it wrong. Thank you, Dr. Bowling. Angela Fitch said in one of her meetings, "It is my genetics, not my character." And she is an obesity specialist. She's president of the Obesity Medicine Association. So she's been in this space for a very long time. She's also someone who has struggled with obesity in her life. And so I've always kind of, and that was just recently, that was in the last 6 months that I heard her say that quote. And it really stuck with me because as an employer, what I believe sincerely is we need to make sure, again, I'm not a provider, but when we think about healthcare, we need to make sure that there are 3 components of working with the disease state of obesity. One is, there is personal responsibility, but what are we doing to help people have dietitians, help them understand what they should be eating? Are we giving them access to programs where they can walk, to healthy communities? Are we making sure they understand that? As an employer, do you have a wellness program that encourages people to have physical activity? So that is very much a large component of helping people with the disease of obesity. A second component that I have learned that is very important also are the anti-obesity drugs. You have I don't like the word weight loss drugs personally. That's Jenny Gowen's opinion. Because I feel like when people say weight loss drugs, they're thinking of those movie stars who walk across the red carpet. They take those drugs so they can get in that pretty red dress, walk across the carpet, and they don't have the chronic disease of obesity. So I'm talking about the opportunity to have access for the patient and for the provider to have that tool in the toolbox of anti-obesity medications. Also, the whole surgery piece. But again, all of these things are tools in the toolbox for the patient and the provider. One of these is not the end-all be-all when you have the chronic disease of obesity. But I think it's our responsibilities in our communities to make sure people have access. One of the things if we go back to that very first slide, and some of you are representing rural communities, one of the very first things that I showed you in those slides are there are a lot of counties in Kentucky that are very rural who are struggling with this disease state of obesity. 1/3 of our population in Kentucky is on Medicaid. Are we making sure that those patients have access to this toolbox with their providers also? I think that's an important component, that this toolbox has everyone have the option and give employers the option. I'm not asking for anything to be mandated, but that employers have the option of using anti-obesity medications because I think it's an important part of the employer's toolbox. Just one more slide is my contact information. I'm not going to stay there. I will turn it over to Dr. Bowling, and then you can ask questions, I think, at the end.
Thank you, Chair Mosier. As I said, I'm Chris Bowling. I'm actually a retired pediatrician as of last year. I've been practicing in Northern Kentucky for about 30 years and been very active in pediatric obesity for the past 20. A lot of what Jenny just presented is echoed in the pediatric community. And I'd like to kind of go over some of the things that we now know about this. Where are we today? 14.1 million children and adolescents in the United States are affected by obesity. And what we know is that children and adolescents with obesity become adults who have obesity. The numbers, this is the corollary, the national chart that Jenny showed you. But what we see from our chart is that our states are affected much like the counties in Kentucky are. Our states that have higher rates of socioeconomic challenges also have higher rates of obesity. A real concentration of high rates of obesity in our southeastern and midwestern states. And Kentucky, as was mentioned, has a rate of about 37 to 38% of adults with obesity. The rates for children, very similar. We're in the bottom 5 in terms of prevalence rates for children and adolescents with obesity. The number of our kids who have obesity is currently at about 25 to 27%, which is lower than the adult population, but many of them will grow into it. And kids who have obesity and overweight account for about 50 to 60% of Kentucky children. Obesity affects both the immediate and long-term health of children. As I mentioned, if you have obesity as a child or an adolescent, you're very likely to have obesity as an adult. But we also know that it affects kids in the here and now. Children with overweight and obesity are susceptible to many diseases, like Jenny mentioned, type 2 diabetes, hypertension, sleep apnea, non-alcoholic fatty liver disease, and depression. Things that I never saw at the beginning of my career in pediatrics, I saw developing pretty rapidly toward the end of that career. Hypertension, as I mentioned, liver disease, dyslipidemias, including changes to cardiovascular function and structure. We also see things that may be less evident, things like a thing called Blount's disease that causes bowing of the tibia. We see sleep apnea in kids. We also see a condition in kids with severe obesity of what's called idiopathic intracranial hypertension, which can be a medical emergency. So obesity, we're not talking about obesity as a cosmetic issue. We're talking about obesity as a chronic disease. I had the good fortune to be on being very active in the area of pediatric obesity. I was on the writing group for the American Academy of Pediatrics publication last year, which was a clinical practice guideline on the treatment of adolescent and pediatric obesity. We reviewed 16,000 abstracts in this article, 1,600 of them full text articles. 382 studies met the scientific rigor that were necessary to make a policy statement about pediatric obesity. From those articles, we came up with 2 technical reports, 11 consensus recommendations, and 13 key action statements. And I'd like to just hit some important ones today. Of these things, the key takeaways are pretty consistent with what Jenny just mentioned. Obesity, like asthma, like ADHD, like cancer, is a complex chronic disease. We would never think, even though those other illnesses can be modified by behavioral things, we would never think to blame a patient for having asthma or ADHD. Sure, it's important to not smoke. Yes, it's important to follow a good diet, but we don't blame them for having those illnesses. We need comprehensive whole child evaluations for our patients. One of the take-home messages that I'm going to hit on very shortly is that obesity treatment is safe and effective. There are effective evidence-based strategies for treatment, and we need to be able to build capacity in order to deliver those. Treating obesity also means treating comorbidities, and that children with overweight and obesity should be offered treatment upon diagnosis. No watchful waiting, in other words. The whole child approach means that we take into consideration genetic, biologic, environment, and social determinants that are the risks for obesity. That's the foundation of this document, and why we see such disproportionate effect in our rural counties and our communities of color and our more disadvantaged communities. It's a complex chronic disease that is often an indicator of structural inequities like unjust food systems, health inequities, and environmental and community factors. It's always a sad factor for me when I drive through Eastern Kentucky and don't find grocery stores, but I do find fast food locations. Genetics, obesity-promoting environments, life experiences, and inequities really make adherence to healthy living very difficult in some of our communities. So what did we come out with from this document? Pediatricians and other pediatric healthcare providers, PHCPs, another acronym there, should treat adolescents and children for overweight and obesity with their comorbidities concurrently. Treating the obesity treats the comorbidities. The treatment recommendations at a very high level, we should treat overweight and obesity in the medical home using a chronic care model, using family-centered and non-stigmatizing approaches that does not say this is your fault, but this is the situation we're in and we need to help you. Intensive health, behavior, and lifestyle treatment works. Pediatricians should provide or refer children 6 and older with overweight and obesity for intensive health, behavior, and lifestyle treatment. These can take a lot of different forms depending on what resources are available in the community. Sadly, We are woefully underserved by these types of programs in the community. Pharmacotherapy. This was a shock to those of us on the writing committee, but when the data came back after reviewing all these articles, we should offer, not mandate, not prescribe, but we should offer children 12 and over with obesity and pharmacotherapy as an adjunct to behavior and lifestyle treatment. Not done in isolation, not done because of cosmetic purposes, but done for health. We should also be in the habit of being able to refer adolescents 13 years and older with severe obesity for evaluation, not necessarily to have, but for evaluation for metabolic and bariatric surgery, to local or regional comprehensive metabolic pediatric bariatric surgery centers, of which, again, there are too few of in our Commonwealth. The take-home message from this document, after looking at a number of items, is that we should start treatment immediately and deliver it intensively for our sickest patients. So I really appreciate your time to be here, and I know that Jenny and I would be happy to answer questions if you have any.
Thank you so much. That was a great presentation, great overview, lots of food for thought, no pun intended. We are seeing a lot more uptake, I guess, of the weight loss, anti-obesity medications, Wegovy, Ozempic. Are those being offered to adolescents? Is that what I'm hearing?
So after, speaking as a pediatrician, that is not something that most general pediatricians feel comfortable at this point delivering. As pediatricians, we've not been great at treating hypertension and what have been thought of as adult diseases. So there are not a lot of pediatricians who will do that. However, what we do is we talk with patients who are suffering from obesity, particularly those who have severe obesity and are having health consequences, that this is a possibility, that delivered in the right circumstance by someone with experience with it. These are discussions that we have with patients.
And if I could, if I could just add, Medicaid in some states has started authorizing the use of the anti-obesity medications for children 12 and up or 13. Tennessee is one of those states, Georgia, Mississippi, Virginia. So these are states that are around us. There are others, but these are states that are around us that are recognizing in that Medicaid population that we need to be taking care of not just our adults, but also our pediatric our children.
Okay, thank you. One more question or observation, I guess. Dr. Bowling, you said that you really didn't see the obesity issue early in your practice, but later in your practice you did, or you were beginning to see more and more. What would you attribute that to?
So, if I had more time I could talk about this forever, obviously, but if I had more time, I would show you the prevalence rates for obesity from the early 90s and late 80s when I started practicing medicine. And those numbers were 5%, 10% of the adult population. Well, now we're getting numbers in the 35 and 40%. I always talk about the cocktail conversation where people say, "Oh, you do obesity work." I think it's caused by sugary drinks. I think it's caused by lack of physical activity. I think it's caused by not having walkable neighborhoods. And my answer to that is, it is. It's all of those things. I think we had a large number of things that happened. I think, like a lot of illnesses, we understand that there's a genetic predisposition and it takes an environmental trigger, much like diabetes, much like asthma, that if we have a tendency and that tendency is not triggered by something, we don't necessarily see it. But when we're met with an onslaught of these environmental triggers on a genetic predisposition, we get what we've wandered into over the last 30 years.
I think that's an excellent point, and makes me kind of think about the blue zones and really being mindful of those factors that really trigger maybe a predisposition. So All right, thank you. We have a few questions. Representative Justice.
Thank you, Chair Moser. Thank you, Dr. Bowling. Actually, I was going to ask the same thing that you asked earlier. Just in your opinion, what you think is responsible for such a drastic change, but you kind of addressed that. Other than that, I was just wondering the school of thought when you're treating some of these patients. Like if you have a juvenile, what is it? What determines when you do the medication versus the surgery, or do you even try any of that at first? Maybe, is there a definite track that you stay on? Or
there is not. And so, one of the slides that I did not put in here, we use a technique called motivational interviewing with our families, where as someone who's always struggled with obesity myself, sometimes you're ready to attack it. Sometimes it's lower on your list of priorities. I've had moms say to me, like, Dr. Bowling, that's great. We should get out and exercise. I'm more concerned about my child being shot when they walk out the front door. Yeah. And I can't say, oh, you need to be worried about this. So I think our role as pediatricians and as physicians is to be talking about it. And when families are ready, when they're able to address it, when it's risen to a level that they can take very important steps for their long-term health, we move. So I think a lot of times it's like a lot of things where you bide your time and you need to be available when they're ready.
Kind of case by case. And
absolutely.
I just imagine a 12-year-old that taking medicine or having surgery, it seems like it would have to be a pretty
absolutely
extreme situation. And I'm a dentist, so in my field, there's always these opposing schools of thought, like periodontist versus the oral surgeons, whether or not you do prophylactic antibiotics with people that's had joint replacements, So,
boy, and our oral health and obesity statistics track county by county.
Yeah,
I mean, we just go in lockstep.
Yeah, thank you.
Thank you,
Representative Callaway.
Thank you. Thank you for the presentation. Very thorough. And yet in the thoroughness, I hear very little talk about the chemicals that we're injecting into our body via the food that we're consuming. Mm-hmm. So while I appreciate the preventative nature of looking at a child and then tracking as an adult dealing with obesity, the idea of not focusing your efforts more on what's in our food, because you just, as you mentioned, you saw that change. I would track that, the food coloring that's being added and some of the other things that are affecting, what are triggering maybe some genetics.
High fructose corn syrup.
Absolutely. I mean, there's a list. I won't go down that path, but what I want to voice the concern about is, while we're having the, the motivational interventions, is that what it was?
Motivational interviewing.
Interviewing, sorry. More talk about the preventative and the foods that the child is consuming. I feel like if we're giving individuals options, take a pill or make a lifestyle change. If those are the options on the table, and I know you, like you said, there's an interview process, but if you're giving people that option every time, maybe not every time, 90% of the time, 95%.
Every time.
Okay.
Every time.
They're gonna want to take the pill. And so I really think it's discrediting us as a society to say that we need to put so much focus in on medical treatments for a condition that majority of the time there are other options. There are absolutely conditions, and I hope I don't come across that I'm discounting that or discrediting any of that you said. And I have the utmost empathy for individuals who struggle legitimately 100%, with conditions. I just don't hear, again, in all of this talk, the focus that I'd like to see on going after our food industry, going, instead of adding medical dependence, we need to be looking at what are we doing in our food industry.
I am so glad you asked this question, because we get asked this. I got asked this on a national talk show once, and I didn't craft an answer very well to it, because I'm a general pediatrician. in my mind, this is a both and sort of question. You know, what we're talking about today is treatment only, and this statement is only about treatment. Prevention, early intervention is absolutely could not be more important. So in my mind, this is not a mutually exclusive or a zero-sum game. This is a both and. And if we're looking forward to the well-being of this Commonwealth, it needs to be a both and game.
And Representative Callaway, I agree. I think this is an excellent question. But the three components that I have been instructed and had people like Dr. Bowling talk to me about it, even though I'm from the employer perspective, it's together. You have to have the lifestyle intervention. You have to learn how to eat healthy. The Kentuckiana Health Collaborative, we're starting a process where we're going to put together a symposium with the Department of Public Health. We're going to bring in farmers. We're going to bring in people who can talk about food, but we have to also remember social determinants of health, and do people have access? You mentioned going through Eastern Kentucky and there are no stores. You are totally right, but I agree also with Dr. Bowling. It's not an or, is lifestyle modification, understanding what healthy eating is, getting physically active, along with if your body is working against you, you may need anti-obesity. Not everyone. You may need that, and then you may need bariatric surgery.
In the interest of time, one of the slides that I eliminated in here was a statement that just from our committee that said monotherapy with medication is never appropriate.
Right. That's excellent.
Thank you. Just one more comment. I would just say addressing it as long as food first and not jumping to food and medication first. Just to be clear, I want to make sure that I'm understanding the motivation here in the program. That it is, hey, let's start here. Let's eliminate this and see what happens, again, with the education process and all. Yes. And thank you again, recognizing some disparities and looking at that. And I appreciate your efforts here. And thank you for allowing my concerns to be voiced.
Absolutely.
Okay, definitely. Thank you. Representative Bentley.
Thank you, Chair Lady. Education has a lot to do with this too. In the state of Kentucky, we have 120 counties. 51 of those do not, as of June of 23, do not have pediatricians to educate the public. So we we need to put more money into pediatricians to get them to go to rural Kentucky, or we need to pass legislature that protects the youth. That's my comment.
No argument here.
Nor here.
All right, thank you. And last question, Representative Riley.
Thank you, Chairwoman. I'm not a scientist. I'm a former educator, former coach, and I just observe things. But here's my observations over the years. When I went to elementary school in the 1960s, I don't remember children with obesity. When I went to high school in the 70s, I don't remember. In fact, obesity was so rare that I can still remember to this day my fellow students that were obese. Mm-hmm. Because one, I felt sorry for them, and two, they were so rare that I can remember them. Mm-hmm. I retired from education in 15. Last year I went to a school play at one of my local high schools, and I was shocked at how many students were obese in that play. Literally shocked. I think in some ways we as a society have cheated our children. I remember growing up, we were outside all the time. That's what we did over and over. We played every kind of game you can imagine. We invented games to play. And in doing so, and by being active like that, I just don't remember. I just don't remember very much of that. In fact, I've seen old videos of people in the 30s and 40s, a society walking down the streets. They're coming out with all these historical videos now, and you didn't see any obesity. You just didn't. And now it's so prevalent, it's unbelievable. And I can remember a student I had in high school, and he was so obese, and he was a great kid. Really thought the world of him. I begged him. I said, "You need to start exercise. You got to do something. You have to." And I said, how far is your mailbox from your house? He says, because he was a rural kid, he said it was about half a mile. I said, can you not like walk to your mailbox and get the mail every day and come back? So we have got to figure out as a society how to encourage our young people. And right now I'm just talking about childhood obesity. I'm not really worried as much about adult, but children. We have got to figure out ways to get them going. I've told a lot of people in school that we literally ought to have 20 minutes of exercise every day in our schools, at minimum, 20 minutes of exercise for every student, not when they're just in PE class, but for every student. You'll see the little kindergartners and the first graders out having recess. It's hard to have recess in the same way for high school students, but physically we ought to have everybody working. And I think research has also shown that the more physically active you are, the better you learn, because it triggers the endorphins in the brain and all that. But we have as a society, we're cheating our children. We are. Yeah, they play video games all the time. They're on their computers all the time.
And we, Representative Riley, we put a lot of burden on our school districts, but the cutting out of a class we used to call home ec, where you learned cooking, and cutting out physical education have not been helpful.
Yeah, my wife wouldn't agree with this, but I did have a home ec class in cooking when I was in high school. Thank you, sir. Thank you for your testimony. Thank you.
All right. Thank you so much for this discussion. I think that it's really been helpful, certainly, thought-provoking, and I think that when we talk about this issue, we're, looking at the emergence of technology, and the video games, and the lack of activity, and just more and more availability of fast food, and a lack of availability of kind of whole foods. So we need to approve some regs real fast if you have 2 minutes. But anyway, thank you so much.
Our pleasure.
I really appreciate your being here.
Thank you.
Thank you.
Yes, thank you. All right. I'm sorry, friends. We just need to take a moment to address the regulations that are on our agenda today. Everyone received the links and summaries. Are there any questions about any of the regs? Okay. All right. Seeing none, I will just make a motion to, well, we don't even have to approve them. Consider them reviewed, so thank you. See no further business to come before this committee. We are adjourned until next Thursday. Thank you.